We're going to be talking about dissociation, this idea of clients going blank, shutting down in sessions. This is not supervision. Also not going to be a neat set of tools where I say, right, when this happens, do this exercise. I will give you some practical options, but before that, I'm going to talk about what therapy clients have said they found helpful. I want us to think about what is going on for a client when they dissociate. What might that person be needing in that moment? And what do we as clinicians need to be assessing, looking for, setting up? And I think importantly, what does it bring up for us? Because there is a reaction in us when things happen in our therapy sessions. So I want to move us away from which grounding tool, which stabilization tool do I use? Obviously, those are going to be things that we're asking, but it shouldn't be the first question. I think the first question, most importantly, is what is happening? What does the client need in order to come back into this present moment, into contact with themselves, with the room, with me? I don't ever remember being taught about dissociation on my clinical doctorate. There might have been a session on it, but if there was, it would have been 1 hour. And I think a lot of this stuff happens when we're with clients actually practicing. When you qualify, you then learn the ropes. So a lot of what I'm going to share has been from practice, being in the room, realizing also slightly more uncomfortably that I didn't always do things correctly. My aim is not to give you a protocol, but more to give you a framework and give you ideas of things that you might not have yet considered. I want you to come away with feeling confident in being able to pause before you reach for your tools, a different way of thinking about dissociation slightly differently, and confidence in recognizing that dissociation isn't getting in the way of the work that you're doing. If someone is finding it really difficult to be present in sessions, that is the work. It tells us something about where the client is at, maybe what their experiences have led to, what they can tolerate, maybe what their parts are protecting them from. And most importantly, it's information for us as therapists on how we might need to pace things moving forward. Today, we're going to start with a broad lens focus. We really want to move away from that diagnostic mindset. This is about our capacity as therapists to assess well, pace a session properly, stay steady and unflappable, and help a client to navigate something that probably is not just happening in the therapy sessions. So wherever you're listening to this, just take a second to orientate to the present. Notice where you are, have a look around you, take a deep breath. Let's get into it. As you know, mastering therapy has been built on practical ways of working, tools that you can use, metaphors, insights. I really love you listening to these podcasts and walking away with a skill that you can try, something that you hadn't thought about before. Practical tools are not a bad thing. I'm all for them. But I really want to offer a word of caution from my own personal experience. When you're working with greater complexity, I think there is a higher risk of perfectionism coming in. We want to do the work well, we want to be useful, we want to be efficient. And this is where we can sometimes, not all of the time, reach for tools in order to try and fix. And so I say a lot of therapists find working with dissociation very difficult and overwhelming and maybe a bit intimidating. And then consequently, we can reach for tools a little bit too quickly. And I just want us to be mindful of that. We have a bird's eye view often of the therapy process. And so we move quite quickly and naturally into sense making, meaning making. And we start thinking, okay, what's the function of this? How does this fit into my formulation? Is this part of a pattern? Which is great. That's part of our kind of clinical thinking, and we need that. But if we try and bring our clients into that too quickly, we are potentially pushing them further outside their window of tolerance, pushing them farther away and making therapy a more distressing experience. So to give you an example of that, let's say you observe a client going really blank in the room. They become less verbal, they're looking off, something has shifted and we jump in. What's happening in your body right now? What is it that you notice? Is there a protective part here? Can you stay with that sensation? What we are doing in that intervention is bringing someone into the body as well as into the present. In the right moment, if the client has capacity, those can be fantastic questions to ask. But if the client is already dissociating, that is where our clinical skills really come into play. We will often see things that the client can't see. We can think about function, parts, protection, trauma responses, attachment. We're thinking all of that, but the client might not be there with us. So trying to pull them into our level of understanding before they're orientated to the present moment to join us, we risk flooding them or pushing them further into a shutdown threat response. The phrase that I'd like you to think about is orientation before introspection. That's something that my supervisor shared with me and I've held in my practice. Before we're asking a client to go inwards, we might need to help them come back externally, back into the room, your voice as the therapist, back into the present moment. The sights, the sounds, the ordinary everyday moments. Then when there's enough capacity, we can move into connecting and exploring what happened. And that's really important also for body-based work. And it includes questions about function as well. Stay with it. That can be really helpful if a client is within their window of tolerance. But if someone is dissociating, they might already be outside of what they can tolerate. So asking them to stay with a sensation can push them beyond what they can actually handle. Some models pace this really well. Think about EMDR. There's a whole emphasis on the preparation stage, stabilization, assessment, and recognizing when process isn't happening effectively. In IFS, when it's done well, there's loads of attention to protective parts, permission pacing, and not just bypassing the system. We don't always know how somebody's going to respond to something, and you might not understand until you're in it what is going on for the client. I've definitely had it where I've taken clients on and I've only realized when we're a few sessions in, when a particular emotion shows up, maybe they disappear or they find it hard to articulate what they want to say. So our ability and our confidence in being able to assess dissociation is really important. Just remember, the first task isn't insight. What are we actually talking about when I use the word dissociation? Before I go any further, I'm not using the word dissociation in a diagnostic term. Clinically, dissociation involves some kind of disruption or disconnection in the way that someone is experiencing memory, identity, emotion, perception, behavior, their body or their sense of self. This can include things like them feeling detached from their body or feeling like the world isn't real, losing a sense of time, not remembering parts of an experience, that idea of watching yourself rather than being fully feeling it or experiencing it. But if we only use the academic definition, it feels too boxy. I'm using it as a descriptive clinical term. I'm talking about those experiences where someone becomes disconnected from their body, from emotion, from memory, from that particular moment. And I think it can be helpful in that it can give language to something that a client might have experienced for years and years. In therapy, I always try and use the client's own words. If they say, I go blank, I disappear, it's like I'm outside of my body, I'd start there. I might use the phrase dissociation as a way of helping them understand that we realize this is often a trauma response or an adaptive response, an understandable response. But I only use that if it helps the client to make sense of their experience as opposed to being labelled by me, because that might not be helpful for them. I wanted to bring some specific client quotes because it doesn't always look obvious from the outside, which is why clinician assessment is so vital. So rather than me describing what I've noticed in my clients, I'm going to take some anonymous descriptions about what dissociation feels like for people from the inside. It feels like voices in my head and noises, but they're sounding so far away and I can't quite hear them. Another described, the world around me feels flat, almost like a TV program, but it's black and white and it's fuzzy. I'm watching it, but I'm not feeling it. Somebody used the metaphor of a car and like the fog on the window screen of the car that they're driving. Someone else described being on autopilot. It's like they can see themselves moving, but they're not in control. I lose all words and language. It's like I can see the words, but I can't say them, and it feels like I'm a bit spaced out. One that I think is really important for therapists for us to be aware of is the person that said, I go into analysis mode when I dissociate. It's like my analytical brain takes over and everything else shuts down. So you see how dissociation doesn't always look like a client staring into space. It could look like a client's reflecting really well, explaining themselves and making sense of the pattern, doing the therapy, but internally they're actually distancing themselves from that emotional material. So they can talk about it, but they're not with it. That could be a form of dissociation. And then the final part is people describing that they didn't recognize it until afterwards. They completely missed a part of the conversation. They can't remember the drive. They don't know what was said in the session. They were aware they were functioning, but not really present. Because imagine that a client experiences this in a session. As the therapist, you don't clock it. The client doesn't have language for it. And so there's a real risk that nobody names it or formulates it. And we don't realize that what we thought might have been silence, compliance, vagueness could actually have been a protective part of them removing themselves from the work. And then we're working around dissociation without actually working with it. A good rule of thumb is not assuming that the body is the safest place to begin. We know that body-based work can be very activating for clients. I'm going to come onto this when I talk about errors. We need to help them come back, to have enough contact with this present moment, the room, the therapist, the sound of my voice, the chair. One of the helpful things that I have found, starting with attention further away before bringing it closer. External before internal is how I've remembered it. Some questions I might ask is about the journey to the appointment, the breakfast that they had this morning, the sounds that they can hear. A quick note on distress versus dissociation. I do want to make this distinction. Dissociation, as I've mentioned, is a clinical term. Distress is broader. And you will know by now, clients are not in neat little categories and boxes. A client can be very distressed and still be very present. An example of this, someone could be crying, they might even be having a panic attack, but they are with you in that moment. They can answer your questions, they can follow your eye contact, they can follow your instructions. They are able to think, reflect, and speak. That's very different from a client who might look very calm and softly spoken or quiet, but who isn't really there. They could still be looking at you and nodding, but they're not taking in the information or what you're saying. And they might say, I don't know, but it's not because they don't know, it's because the words have gone. And that might be them having the outer body experience, feeling quite vague or even becoming very compliant. So not putting up any resistance to what you suggest, which is why we really need to be mindful of how we're working. This isn't to force you into, is this distress or is this dissociation question, but more, is the client present enough in that moment to do the work that I'm asking them to do? And obviously distress and dissociation can overlap. Someone can be panicking and dissociating. Someone can be crying and not be present. If we think about this from a CFT perspective, thinking about the threat response, panic could look like mobilized threat. There is that energy, that urgency. They need to escape and need to do something. But dissociation can look more like collapse, shut down, disconnection, going blank, becoming detached. I know Polyvagal theory's got its controversies, but this is where that dorsal vagal shutdown fits. Also, the idea of depersonalization, where someone feels disconnected from their body or their sense of self. Or derealization, where the world feels distant, flat, strange, disconnected. I'm only going to mention this very briefly. This is not a lecture on structural dissociation, but as I'm talking about it, I can't not talk about this. There are people that can teach on this in far greater depth with far more experience than I, but the basic idea is very clinically helpful. Structural dissociation, in a nutshell, is understanding how trauma can create divisions within the personality system. So in the simplest version, you might hear people talk about apparently normal part, ANP as it's called, or an emotional part, EP. The apparently normal part is that part of somebody that is getting along with normal life. It goes to work, it does the school run, it forms friendships, it comes to therapy, and it can sit in the chair and say, yep, I'm ready to work on this, I'm ready to explore this part of my history. The emotional part is more connected to trauma, threat, defensiveness, survival. That is a very simplified version, but it's useful if you are IFS trained. This will not be an unfamiliar concept to you that we can have parts that are in conflict. In the room, you might have a client that says, yes, I'm up for doing that work. And then another part that says, absolutely not. And it doesn't say it verbally, but it says it through the response. Dissociation, shutdown, going blank, losing words, feeling far away. Through the body, they are saying, we are not doing this, we're not going there. And the reason it's complex is that technically you've got that consent from the client because they've agreed to talk about their history. They might say, yeah, great, let's do a body scan. You begin and it activates something in the client and they disappear. And then maybe the rest of the session, instead of exploring the thing they'd agreed to, is spent you trying to bring them back to the present moment. We're not at this point labeling, oh, this is structural dissociation. Please don't do that because I don't think that's necessarily going to be helpful for the client. But it reminds us that a client's verbal yes might be different to another part of them that is very much not saying yes. We have to hold in mind that we're not just listening to the adult, reflective, polite answer. We need to think about someone's system as a whole. When I say dissociation is the work, it's telling us, hey, you might be getting too close to something here. This is a protective response that's just shown up. This doesn't feel safe enough. I don't have capacity to be able to go there with you. Which is very different, isn't it, from seeing dissociation as something that we need to quickly fix, or let's just do these tools so we can then go somewhere else. And it's really important that we respect that one part of the client might be ready long before another part is. Moving on to common therapist errors, and I say these knowing that I have made some of these mistakes and I feel that sense of ugh when I recount it, but we have to be kind with ourselves and have learnt from the mistakes that we have made. One of the big errors is around going into the body too quickly. If you ask AI for clinical leading, do you know what it 9 times out of 10 will do? Ask the client where they feel it in the body. Obviously, it's generic advice. It can be useful, but that is not always appropriate for all the reasons that I've described earlier. Because a body scan sounds great, like a stabilization exercise, but it could also bring someone closer to the sensations, the threat response, the memories that they don't have capacity to stay with. If you think about the 5 senses, a great exercise to do with people, really easy. What can you see, hear, smell, touch, taste? But there's still body in that, and that's the bit we have to just be mindful of. The external cues sitting outside of the person and the internal cues being things within them. Internal cues invite them to go inwards, their chest, their breath, the sensation in their throat, their heartbeat. Useful, but not necessarily the first place to go. Another common error is stay with it and doing that too quickly. Again, very useful phrase in the right context. If you're processing in the EMDR, you might say stay with it or go with it. But it can become ignore your stop signals, and another version of overriding, which we really don't want. And let's remember that for those with trauma histories, that overriding is not an unfamiliar experience. I might say something like, can we stay near it, or do you need to come back out? Is this too close? Do we need to pause? Can we come back to the room for a second? Which gives the client choice. Another error is moving from understanding to insight. What's the function? What's this protecting you from? Which part is here? Who does this remind you of? What does it remind you of? Good questions in another context, but timing is everything. And if someone's not fully with you, they're not going to be able to use those questions anyway. Another error I want to mention is silence. Now, silence can be so useful in therapy. It really can be quite powerful. But during dissociation, it can get quite complex because some clients might experience silence as holding space. Other people might experience it as abandonment. So they might be sitting there frozen, and the therapist thinks, oh, I'm giving my client space. But the client could experience that being left alone with something that's incredibly unbearable. So again, we need to know the client. We need to ask afterwards, when I was quiet, did that help, or did it feel like I disappeared? Would you prefer me to say things in those moments when I notice you going away, or would you like me to be still? Does my voice help you come back, or does it feel too much? And another error is the opposite, overcompensating, talking too much. This usually is therapist anxiety. We throw 10 grounding strategies because we're anxious. Look around the room, feel your feet, take a breath, name 5 things, hold this, tell me what you can hear. And the client's sitting there thinking, if they can think at all, please stop. One of our key roles is to be an anchor in the room in those moments and to feel confident in being able to slow things down. If you notice that you're repeatedly feeling dread before sessions, you feel anxious because you don't know what to do when a particular client dissociates, that is really helpful clinical information. Take that to supervision. That might mean, okay, I know what my next training is. I might need to pause with this client or slow down. Maybe this client needs a different level of support. Finally, the practical exercises is only useful if the client has enough capacity, consent, and sense of relational safety to actually use these tools. And the same exercise can be grounding for one client, destabilizing for another, be fine for one client on the Tuesday, and by the next Thursday, it doesn't work for them for whatever reason. They're not magic tricks, they're just possibilities. What does this client need in this moment to bring them back to present day? Sometimes that might be external cues like sounds and smells or movement, throwing a ball or an object back and forth. It might be about using the ground beneath them to ground them, getting on the floor instead of going inside the body, like actually lying on the floor. We are always assessing, can the client hear me? Can they respond? Are they more present or less? Am I helping them to come back, or am I asking too much? And then we've got, what do we do before, during, and after? Now, the reason that this is important is because the work you do before can be really useful. I think we want to know as much about our clients as we can, and some models use scales like questionnaires for this. Some therapists ask clients to rate on a scale how they feel. You might not use a formal scale, but if a client describes these moments, it is worth doing a little bit of a quick assessment. What are the early signs? What happens first? Do they stop making eye contact? Do they lose words? Do they become very still? Do they start saying, I don't know a lot? Do they become very analytical? And maybe agreeing a plan with them. So ask them, is it a hand gesture they would like? Is it a particular word they'd like to say? It could be touching the arm of a chair. It could be saying the word pause. What we're doing here is we're planning for those moments where the client doesn't have those words. And you might ask them, when this happens outside of our sessions, what do you find is most useful? Is there something that makes it worse? Do you find it helpful if someone speaks to you? Do you find the breath is an anchor, or does it feel a little bit more overwhelming? The aim is that we want it to be collaborative, right? They are an expert in their experience, and often clients will know what works for them and what doesn't. And this is why I talk about it a lot. Getting feedback from your clients as to what is helpful, how they experience you as a therapist, will help you develop as a therapist, but also help your relationship with them. And that therapeutic relationship we can use as another cue, one of those external cues. Can you hear my voice? Can you look around the room with me? Can you let me know with a little nod if you can hear me? I had one supervisor that I was observing on training, and they actually got some water and the client was not responding to them. They said, okay, I'm about to pour some water onto your lap. Let me know if you can hear me speaking. And that brought the client back. You might have some sweets in your office, or mints, or a candle, or something that elicits a strong smell. Using sensory intensity to pull someone back can be quite a good strategy for some people. We might get them to hold a textured blanket or a cushion, a weighted object or a spiky ball, something really silky, something cold. Or we might use movement, standing up, sitting down, lying down. Again, you have to be careful with this. I remember offering one client, right, should we just both get on the floor? And I got on the floor and she couldn't move. I kind of misjudged that in that moment. We just have to know our clients. And sometimes you don't know until you've worked with them for a bit. You might use something playful like Simon says, touch your shoulders. Simon says, press your feet down. Simon says, I know that it sounds a bit silly when I'm saying it like this, but sometimes the silly really works. And I have had that work for me. So I don't dismiss anything these days. Now, this isn't going to work for everyone, but using cognitive tasks, counting backwards from 100, naming countries beginning with a certain letter, doing simple sums. Can you tell me what 5 + 4 is? You're getting the client to think outside of themselves. And so that can be helpful when the body feels too activating. And afterwards, making sure that we debrief with the clients what was helpful. And maybe you don't do that in that exact session. It might be part of the work that you begin with in the next. When they're back, you might debrief. Did you notice yourself leaving? Was there anything that I did that helped? If you've named dissociation with someone, it might be helpful to follow that up with a resource that they can read or a YouTube video that they could watch. It normalizes the experience. And then finally, I just want to say, with ending difficult sessions where you've needed to do a lot of grounding work in a session, I'm very much in favor of keeping the time boundary in sessions. And I don't believe that therapists should routinely overrun. I think doing that because the session was difficult is not helpful for clients or particularly containing. However, if somebody is really distressed and you've been doing 10 minutes of work but it isn't quite enough, those are the sessions that I would overrun on. I think we have a moral obligation and an ethical obligation to make sure a client leaves a session in a stable and coherent way. We're going to end this episode by naming a few resources. I've linked these in the show notes. The first resource is called Finding Solid Ground. I'd probably start here if you want something structured and practical. It's designed for people experiencing complex trauma symptoms. And there's a workbook for clients and material for therapists as well. There is a great book called Treating Trauma-Related Dissociation by Kathy Steele, Suzette Boone, and Onno van der Hart. And Otto van der Hart also has a great book called The Haunted Self. They aren't like bedtime reading, but they are helpful. I'm running a series of workshops on the bits that we were never taught in the therapy room. We're going to go into this in a little bit more detail with some practical exercises and examples, but I've also got a guide of some of the tools as well that you can download if you're interested. I don't want you to finish this episode thinking like, great, now I know how to treat dissociation. This is not about treatment. It's just giving you a better clinical frame and some things to think about. Pause before reaching for tools. Think about orientation before introspection, and to know where to go next if you need a bit more training or to think a bit more about this. I hope it's been helpful. I'll see you next time. Thank you for listening to this episode of Mastering Therapy. All of the resources mentioned are available in the show notes. If you're interested in getting more information on what's been covered this season, you can sign up to our mailing list or visit the website masteringtherapy.com. If you know someone that would be great to interview on this podcast, you can submit a recommendation and I'd love to hear from you. The Mastering Therapy podcast and the information provided by me and my guests is solely intended for qualified professionals for information and educational purposes. I look forward to you joining me next time.